Welcome to our second video on spinal cord diseases. Let's begin. In this lecture, we're going to discuss Cauda Equina syndrome, Syringomyelia, and Transverse Myelitis. We'll discuss definition, etiology, clinical features, diagnosis, and management of Cauda Equina syndrome. Cauda Equina syndrome is defined as the compression of spinal nerve roots in the lumbar and sacral regions of the spinal canal. Let's take a look at this illustration. We can see here the spinal canal. Please note the Cauda Equina. It is composed of spinal nerve roots in the lumbar and sacral regions of the spinal canal. Cauda Equina syndrome can occur due to several causes, most commonly include vertebral disc herniation, epidural abscess, epidural tumor, and lumbar spine spondylosis. Cauda Equina syndrome is an emergency presentation, so we should be aware of its clinical features. The patient presents with back pain that radiates to one or both legs. There is loss of sensory and motor function in lower extremities. For example, weakness of plantar flexion and absent deep tendon reflexes can be seen on physical exam. Saddle anesthesia can also be present. This means diminished sensation in the perineal region, groin, anus, and upper thighs. And finally, bladder and bowel dysfunction may be present, such as urinary or fecal incontinence. The diagnosis of Cauda Equina syndrome is essentially clinical. However, MRI is the imaging test of choice and can be used to evaluate and identify the cause. The management includes emergent surgical decompression. Let's take a look at this MRI of lumbosacral spine. We can see a lesion in the posterior epidural space that compresses the Cauda Equina. Let's do a review question. A 7-year-old woman comes to the physician due to urinary and fecal incontinence for the past week. She reports an unintentional loss of 15 kilograms and severe back pain during this time. The physical exam reveals flaccid weakness of the lower extremities with 1+ deep tendon reflexes. Perineal anesthesia is noted on the sensory exam. What is the best next step in diagnosing this patient? This elderly woman presents with urinary and fecal incontinence along with severe back pain for the past week. Physical exam reveals flaccid weakness of the lower extremities with 1+ deep tendon reflexes. Perineal anesthesia is noted on the sensory examination. Urinary and fecal incontinence, back pain, lower extremity weakness, and saddle anesthesia raise suspicion for Cauda Equina syndrome. Given an unintentional loss of 15 kilograms in a month, the most likely cause of our Cauda Equina syndrome is malignancy. The best next step in diagnosis of Cauda Equina syndrome is an urgent MRI of lumbosacral spine. Next, we'll discuss Syringomyelia. We'll discuss definition, etiology, clinical features, diagnosis, and management of Syringomyelia. Syringomyelia is a fluid-filled cavity within the spinal cord that damages adjacent spinal tracts and structures. It can be a dilation in the central canal or a separate cavity within the parenchyma of spinal cord. Moreover, Syringomyelia often affects the cervical or thoracic cord, particularly the segments from C2 to T9. There are several conditions that are associated with or can result in the formation of Syringomyelia. These include Chiari malformation type 1, which is the most common, neoplasms such as ependymoma, and post-spinal trauma. In addition, infections and inflammatory disorders such as transverse myelitis can be ensued by Syringomyelia formation. Let's discuss clinical features. Syringomyelia can be asymptomatic. However, when it is symptomatic, it has the typical manifestations of central cord syndrome. Hence, bilateral loss of pain and temperature sensation over the upper back, neck, and arms is noted due to damage of spinothalamic fibers in the anterior white commissure. This is called the cape-like distribution. Remember that Syringomyelia usually affects the cervical and thoracic spinal cord, so the affected dermatomes are those of the upper back, neck, and arms. The lesion of Syringomyelia can extend to compress the anterior horn cells of the spinal cord. This will result in a typical lower motor neuron lesion presenting as flaccid weakness and diminished deep tendon reflexes at the lesion level. Here's a cross-section of the spinal cord with a human outline. As we mentioned, symptomatic Syringomyelia usually has the classic manifestation of central cord syndrome. The damage of spinothalamic fibers in the anterior commissure leads to bilateral loss of pain and temperature sensation in cape-like distribution. For the diagnosis of Syringomyelia, MRI is the best imaging test. It usually shows a fluid-filled lesion. Management can be achieved by surgical decompression and shunt placement. Here is a spinal MRI showing a fluid-filled lesion consistent with Syringomyelia. Next, we'll talk about transverse myelitis. We'll discuss definition, etiology, clinical features, diagnosis, and management of transverse myelitis. Transverse myelitis is defined as acute inflammation of spinal cord segment or segments. It most commonly affects the thoracic cord and may be primary or secondary, aka disease-associated. So transverse myelitis can be primary or idiopathic, which is the most common. However, it can be associated with infections, most often viral infections such as enteroviruses and bacterial infections like mycoplasma. It can also be associated with central nervous system disorders, for example, multiple sclerosis. Lastly, transverse myelitis may occur in the context of systemic inflammatory autoimmune disorders, including sarcoidosis, lupus, and Sjogren's syndrome. Let's discuss clinical features. Transverse myelitis is of acute or subacute onset. The patient presents with bilateral weakness and altered sensation, such as pain and paresthesia. Autonomic dysfunction like bowel and bladder incontinence and sexual dysfunction is usually encountered too. Importantly, on neurologic examination, sensory level is identified, which helps expect the lesion level in the spinal cord. Recall that sensory level is the lowest level detected on physical exam with normal pinprick and light touch sensation. The sensation is absent or diminished below the sensory level. To diagnose transverse myelitis, MRI with or without gadolinium is usually performed. It shows gadolinium-enhancing signal abnormality over one or more segments of spinal cord. Also, lumbar puncture should be performed. The cerebral spinal fluid analysis shows moderate pleocytosis, elevated protein, but normal glucose. Let's take a look at this spinal MRI. It shows gadolinium-enhancing signal abnormality that suggests transverse myelitis. When the diagnosis of acute transverse myelitis is established, high-dose intravenous glucocorticoids should be administered. Plasma exchange may also be considered, especially when there are motor deficits. The prognosis includes partial recovery in most idiopathic cases within 3 months. Let's end our lecture with a board-style question. A 35-year-old woman presents to the physician reporting urinary and fecal incontinence for the past month. She has a past medical history of poorly controlled multiple sclerosis. Her vital signs include a temperature of 36 degrees Celsius, blood pressure of 110/75, heart rate of 88, and respiratory rate of 16. Physical exam reveals loss of vibration, proprioception, pain, and temperature sensation bilaterally below the level of nipples. Spastic weakness and 3+ deep tendon reflexes are noted in the lower extremities. The upper extremity exam is unremarkable. MRI with gadolinium enhancement shows enhanced signals at T4 spinal cord segment. CSF analysis after lumbar puncture reveals 30 lymphocytes, 50 of protein, and 60 of glucose. Which of the following is the most likely diagnosis in this patient? A. Transverse myelitis. B. Amyotrophic lateral sclerosis. C. Anterior cord syndrome. D. Central cord syndrome. This young woman with poorly controlled multiple sclerosis presents with urinary and fecal incontinence for the past month. The physical exam reveals loss of vibration, proprioception, pain, and temperature sensation bilaterally below the level of nipples. Nipple line in this case is a sensory level below which all the sensations are impaired, suggesting damage to both dorsal columns and spinal thalamic tracts. Spastic weakness with 3+ deep tendon reflexes are noted in the lower extremities, indicating damage to the corticospinal tracts. MRI with gadolinium enhancement shows enhanced signals at T4 spinal cord segment. CSF analysis is significant for mild pleocytosis evidenced by 30 lymphocytes, and mildly increased protein with a level of 50. All these findings point to the diagnosis of transverse myelitis. Transverse myelitis is even more likely given the patient's history of multiple sclerosis. Therefore, the correct answer is option A. Here is a slide reminding us of the clinical features of transverse myelitis. Let's discuss why other options are incorrect. Option B is incorrect because amyotrophic lateral sclerosis is not characterized by sensory disturbances. Additionally, it usually presents with flaccid weakness in the upper extremities, which is absent in this patient. Option C is incorrect because anterior cord syndrome damages all major tracts except the dorsal column system. This patient has lost vibration and proprioception, indicating dorsal column damage. Therefore, anterior cord syndrome is excluded. Finally, option D is incorrect because central cord syndrome is characterized by loss of pain and temperature and the flaccid weakness at the level of the lesions. In addition to pain and temperature sensation, this patient has also lost vibration and proprioception, and she has spastic rather than flaccid weakness. And that concludes our lecture on spinal cord diseases.